my name is Jessica Veach, and I'm the Program and Outreach Manager at the Epilepsy Foundation Northwest. Our next speaker, thank you. Our next speaker is Dr. Vossler. Dr. Vossler will speak on the topic of anti-seizure medication and medical marijuana. Dr. Vossler is the Medical Director of the Neuroscience Institute at Valley Medical Center and a Clinical Associate Professor of Neurology at the University of Washington. He has authored over 50 scientific articles and has served on journal editorial boards and boards of national neurology organizations. Dr. Vossler also serves as an executive committee member of the Epilepsy Foundation Northwest Professional Advisory Board. Please welcome Dr. Vossler.
Well, that was an excellent talk by Dr. Hamuka, and I'm going to expand on that a little bit, but talk about treatment. As you may know, there's 26 anti-epileptic drugs now available to us, so I'm not going to be talking about all 26 because I only have about 30 to 40 minutes to speak, and then you won't get to hear about marijuana, which I know everybody wants to hear about. So. And no, I do not use it. I never have. I'm not even like Bill Clinton. He just didn't inhale. So anyway, I'm the medical director at Valley, and I'm actually a clinical professor now, Jessica. So we'll have to, I got a promotion. That's a good thing. And I chair the treatments committee for the American Epilepsy Society. I guess I need this. Eh? Here we go. Lori Hamuka kind of didn't talk too much about the types of seizures, and I didn't know if I should or shouldn't. I'm glad I included the slides because we need to talk about the types of seizures because the treatments are driven by what kind of seizures you have. And there are 10 kinds of seizures. I think most patients don't know that. There are about 40 kinds of epilepsy. Most patients have no idea that there are that many. And again, we have 26 approved anti-epileptic drugs. If you kind of discount some of the old look-alike kind of drugs, we'll do that. So I won't be talking about all of them. I'll talk about the new ones that have evolved since 2009. And I'll talk about some experimental anti-epileptic drugs that are really kind of close to the finish line in terms of getting approval, because everybody really likes to know about what's new. I always say we don't read Olds papers, we read newspapers. And I think that it's kind of always nice to know what's on the horizon. Then I am going to talk about cannabidiol. I think the day is almost here where we're going to see this drug approved, and I'll tell you about that at the end. So I'll leave you in a little suspense so that maybe you'll listen through the whole thing. Seizures are a sign, which is something you can see, or a symptom. Symptoms are something that a person feels of a disorder, okay? And epilepsy or epilepsies are the disorders. And Lori said that seizure disorders are the same as epilepsy, and that's true, but I think it minimizes, to call them seizure disorders really minimizes what's going on. And in her talk, she did a wonderful job talking about all of what we call comorbidities, all the things that go along with having epilepsy. So seizures are only a part of it. There's this whole big spectrum of problems, which she did a great job talking about, and I won't do at all. So you need to know what kind of seizure or seizures you have. I can't tell you, I've been doing this here 30 years, and not to correct Kevin Kopis, but I've been around the Epilepsy Foundation Northwest for 30, this is my 30th year. We started our first epilepsy awareness symposium, we called it a consumer fair back in those days in 1993. And Bob Fraser, who's the only guy in the audience with more gray hair than me and has been around longer than me here in Seattle. Congratulations, Bob, and thank you for your years of service. 40 years, I think, right? Something like that. Anyway, we started this in 1993, and we were at Highline College, and we had 300 people because it had never been done before. It dropped immediately because people had been there, but it's great to see things happening. And what's really exciting is there's so much changing in epilepsy in the world today that I think it's fun. It's a fun time. It's a great time. These 30 years in Seattle have been just fantastic in terms of what has changed in the field of epilepsy. But you need to know what kind of seizures you have, because people come into my office and I say, they've been having epilepsy for 20 years. And I say, well, what kind of seizures do you have? I have petit mal and grand mal. What is that? I mean, I'm not kidding. That's what people say. Maybe many of you, that's all you know about your seizures or your loved one's seizures. Please, guys, learn the terminology because people are mobile. People move around. And when you go see a new doctor, it's not okay to say, I have petit mal and grand mal seizures. That doesn't work because that tells you nothing. It's like telling a cardiologist you had a heart attack. What's that? So you need to know the terminology. Here's the terminology. So let's learn this. Okay, focal onset seizures. Seizures can begin in a spot in the brain, or they can begin all over the whole brain, everywhere, all at once. That's it. There are two main classes. If you go in a Chinese restaurant and you select, you can select from column A or you can select from column B. You pretty much don't go across those lines. This is column A, focal onset, localized onset. The old name was simple partial, but it was so crazy a name that in 2010, the ILA changed it, and we call it focal seizures without impairment of awareness. The next step up, and you can start with those, that's a simple partial seizure. The next step up is what we used to call complex partial, or it's a focal seizure with altered awareness. People there typically have movements, they do funny things, they're unaware. They're not unconscious, but they have altered consciousness. And then finally, those can progress to full-blown, what the Spanish call convulsions. Convulsion is a Spanish word. Grand mal, grand maladie means big illness in French. Big illness doesn't help me, so don't call him, stop it. Don't call him grand mal anymore. Let's use some terminology here, okay? So focal seizures, as Lori said, begin in a spot in the brain, and depending, I don't know, do I have a pointer here? Yeah, I think so. Depending on where in the brain they begin, you have different signs and symptoms. If they begin in this red strip of cortex here called the motor strip, you'll have focal motor jerking or symptoms like that. If it begins in the sensory cortex, then you'll feel things in the opposite arm, right? Because the brain is cross-wired. Right side of the brain affects the left side of the body. If it's back in the occipital lobe, you'll have visual alterations. And the most common lobe of the brain that seizures come from is temporal. Good. Temporal lobe, absolutely. And people there, if it's more than a sensation, more than deja vu or something like that, or a funny smell, or just that aura that Lori talked about, and I define it a little differently than her, but that's okay. So that if it goes beyond that, you have altered awareness, things like lip smacking, chewing, staring, maybe fumbling around with your hands. And that's what you're seeing down here. So those are focal seizures, and they can progress to tonic-clonic convulsions. Okay, this is column B in the Chinese restaurant. This is a generalized onset seizures. These are seizures that begin all over the whole brain all at once. And now these are a little bit artificial distinctions. You're gonna, I know some of you in the audience, and you're gonna say, well, I'm, my kid, or I'm somewhere in between. But you're the exception. These are the rules, and there's always exceptions. But in any event, generalized onset seizures begin everywhere all at once. And I'm looking at someone in the audience who has generalized tonic-clonic seizures. These occur with no warning, no aura. They begin all at once everywhere, and they are very dangerous because of that. There's no warning, and bam, these people go down. And the person who has these just winked at me, so I know, well, this person knows what we're talking about. And then we have people who have absence seizures. Those are the little ones where you just stop and stare and flutter your eyelids and are motionless and then come back. And there's different forms now, typical and atypical we had in the old classification scheme, but in the new 2010 classification scheme, we added a few rare ones. Don't worry about those. My daughters had these. My daughters never had febrile seizures, but my wife had one with a DPT shot when she was a kid, and her mother had some funny little things, and both of my daughters had myoclonic seizures. Well, they're both college students now, and they outgrew them many years ago, which much to my delight, I must say. And so these are fairly common. And Like Lori was talking about, Dr. Hamuka, she was saying a lot of times these things go on for many, many years, and especially teenage boys thought, oh, I thought everybody did that. Doesn't everybody twitch like that? And we all do twitch a little bit in our sleep as we're drifting off to sleep, but not sitting here in the middle of the day. You don't, throw your leg out or just heave a cup of coffee at Dr. Novotny or whatever. So, although probably some of his residents may have wanted to do that, I don't know. But any event, and then you do have, and then there's other rarer types over here, which I'm going to not bore you with. And then I will say, finally, there's an unknown category because it's a little unclear with what we used to call infantile spasms, but now we call epileptic spasms. Sometimes it's a little unclear whether they're really generalized or focal or kind of both. So there is sort of a little gray area, but let's keep it simple. So these are absent seizures. They begin all over. Oh, got my finger there. Okay, all over the whole brain all at once with 3 per second spike and wave. And this is meant to, in a still photograph here or diagram show you what an absence looks like. And these are tonic-clonic seizures. There's a loud epileptic cry, and the patient stiffens. That's the increased tone in the activity, so hence tonic. And then clonic means claw. The word clonic means claw because the hands sometimes claw up. They often flex, but they can extend. And there's what we call jerking. I detest the term twitching. Our nurses constantly call me, oh, the patient's twitching. What's twitching? I don't know. Is it clonic? What is it? Tell me, jerking. And then afterwards, of course, the person may have tongue-biting urinary incontinence, and that's the postictal phase that Dr. Hamuka was talking about. So this is overwhelming. I'm just going to show it and just move on. There's 40 kinds of epilepsy. It's really good for you to know what you have. Okay, you don't need to worry about the other 39 kinds. So ask your doctor, okay, I have, myoclonic seizures and generalized tonic-clonic seizures. It's generalized. I have a syndrome. My syndrome is juvenile myoclonic epilepsy. Another person has complex partial seizures with altered awareness. Sometimes they progress to convulsions, okay, but they come from the temporal lobe. They're focal. They have temporal lobe epilepsy. You should know that. Don't go around not knowing what you're treating. Because if you move to Pasadena and you see a different neurologist, it's going to save you a lot of headache and a lot of wasted time and repeat testing sometimes if you know these things. Because the treatments are based on knowing what's going on with you. Okay, so the goals are really simple to state. And as Dr. Hamuka was saying, not always so easy to achieve. So long-term seizure control. The thing that helps people with epilepsy the best is 100% seizure freedom. Let me say it again, 100% seizure freedom. People have done research studies, your tax dollars have funded research studies over and over again, and when people get the best quality of life, have the best psychosocial outcomes, the best mood outcomes, it's because they're seizure-free. You have to be seizure-free. Now, having 1 seizure a year as opposed to 90 a year, which I just recently had a patient I never thought would happen, and I'll tell her this to Rusty too. This is an Dr. Novotny, it's an interesting story. There's lots of us old guys, professors around the world that say, oh yeah, all temporal lobe epilepsy is really horrible, and you always have to have surgery. And well, that ain't necessarily so, as the song goes. I had a patient who came to me in 2010, was having 90 complex partial or focal seizures with altered awareness a year from temporal lobe epilepsy, right temporal lobe. He has hippocampal sclerosis. I told him, you need to have surgery, you need to have surgery, you need to have surgery. This guy has now been completely seizure-free with 3 medications, albeit 3, but he's tolerating them well, completely seizure-free for 18 months on medication. I'll take some credit for that because I did that for him. But, well, listen, believe me, in our clinic, I celebrate the wins. That's what we're there for. That's what we're there for, is to win and to celebrate it. You gotta enjoy the happiness. But anyway, not everybody is seizure-free, but it can happen, and you need to keep going. You need to work toward that. We want to get those quality of life benefits. We want to be safe. And when we get to marijuana, I'm going to talk about that some more, about safety, okay? Because I think that's a point. Patients do need to adhere to the treatment plan, and there need to be no other medication interactions. one of the things that was said, and I'll maybe correct it a little bit, there was a big study that was done in Dr. Novotny's institution by a lovely, actually, nurse, Joyce Kramer. Joyce did a wonderful study with medications. They put computer chips in the caps of anti-epileptic drug bottles. And she looked at if you take medicines once a day versus twice a day versus 3 times a day versus 4 times a day, actually the results were, I'll differ a little bit with Dr. Hamuka, no disrespect, but I remember this, and Rusty, you may too. What they found was that if you take meds once a day, your compliance, your ability to adhere, to stick with the plan is really good. It's like 90+%, right, Rusty? If you take it twice a day, actually it's pretty good too. It turns out twice a day meds are fine. The problem is 3 times a day is very bad. And in the old days, before we had long-acting carbamazepine products, we used to dose it 4 times a day back when I was a fellow here in the 1980s, because it was a very short-acting drug. People can't take drugs 4 times a day. Simply can't do it. They're always going to make mistakes. So once or twice a day, that's the message I want you to remember. Twice a day meds are okay. You don't have to take them once a day. And the other thing is nobody's perfect. Well, okay, what about the meds? Does that look overwhelming? That's a good thing, okay? Because when I came to Seattle, this was where we were, okay? And in 1978 was the last new medication for 15 years. And I think back on that, and don't you agree, Rusty? That was like the dark ages. We knew these drugs cold, and we combined them in all kinds of toxic combinations over and over again because we didn't have anything else. We did not have anything else. And in 1993, the floodgates opened. And I have to say I'm proud that I've investigated every single one of these drugs, except for maybe 1 or 2 over the last 30 years. So pretty exciting. So it started back in England with Locock and with bromides, and I won't get into that. And then phenobarbital, and here's an old phenobarbital from the Massengill Company in Bristol, Tennessee. That's an old bottle. And these are the years of introduction of the different anti-epileptic drugs. But we've, again, this is the sort of, if you will, second generation. I don't like that term because it implies second generation, well, that must be better. Well, I'm not so sure they're better. I do think they generally have lower toxicity and better side effect profile, but they're not necessarily more effective. So I'm going to start. You can see all of these ones we've worked on over the years. I'm going to start here. And the ones in red, I'm going to talk to you about a little bit more. And then we have a couple new ones this year, which is pretty exciting. So it keeps coming, guys, and that's the good news. So this is for the doctors in the audience. There's a couple here and a couple of nurses I see. Hello to all of you, my colleagues. And so you don't need to know this if you're a patient. You can't remember it anyway. But we have guidelines. These are guidelines. Yeah. Well, it doesn't hurt, right? Let's go back. It doesn't hurt to know these things. I mean, these are guidelines from the International League Against Epilepsy, the American Academy of Neurology, and randomized controlled trials. So we spend a lot of time doing controlled trials. Dr. Kawaguchi, who's sitting in the audience, she's going to talk later. She's investigating a new drug with me, and we have very strict protocols we have to follow. I see one of my drug study participants here in the audience as well. And, you know, thank you for people who do that, because that's where these new drugs come from. But we now know that even for some specific syndromes, we do have indications for certain medications, as you see here, and we're going to have more. So real quickly, I'm just going to go in alphabetical order. I do speak for some of the pharmaceutical companies. I play no favorites. I'm here for you, patients, not for them. But I do work with them because it benefits you. If I didn't work with them, didn't educate doctors, and didn't do research on these things, we wouldn't have these new products. So this drug is called brivaracetam. I'll just use generic names. You know that there's a difference between generic name and the brand name. A generic name is the chemical name of the drug. The brand name is the one that's chosen by the company that first develops it. And if you want more information, by the way, about generic anti-epileptic drugs, that question may come up. Look in the journal Neurology, the green journal. You can go online. I wrote 2 pages for patients. It's what's called a patient page. It was published in the October 25th issue just last week. Well, before Halloween, whatever that was. And the issue of generics is, I discussed it really well in layman's terms, so hopefully you can understand that. So this is a new drug for focal onset seizures, and this is doctor speak. You down here, you don't need that. Okay, these are for doctors, but I thought I'd just throw them in here to kind of give you an idea. So, you know, many of these drugs have central nervous system effects. Well, that's because they work in our brain, right? So they work in our brain, but they also tend to have side effects in our brain, and here are some of them. This was just approved in February, actually not marketed until June. So we're talking about the newest kid on the block here in terms of a medication. Carbamazepine, this is not a new drug. This was developed by Roche in 1974 in France for trigeminal neuralgia. That's what the drug was for neuralgia. And later they found it worked for epilepsy, and boy, did it ever. This has been a mainstay, of course, of treatment for 40 years and a great drug. We now have it. The only purpose of showing the slide is we have an intravenous form that was just approved less than a month ago. So this really only comes into play if you're in the hospital for some reason and you're on carbamazepine and can't take it. Let's say you're having stomach surgery and you can't eat. You're not allowed to eat. Okay, clobazam. Clobazam has been around the world since 1974, I believe also. It's available in 100 countries as a generic drug. It's been available in Canada for decades, but we couldn't get it to the United States because it takes a lot of money to get things approved by the U.S. Food and Drug Administration, which is our watchdog administration. It's here for our protection as citizens, and that's a good thing. But it also takes some money to get it through that process. And so one company did that. They have a display outside. I'm not promoting it, but I'm just telling you. It's called Onfi. And the reason is because of the ring structure. This is for the chemists in the audience, this is the chemical structure for clobazam. And the positions of the nitrogen atoms in this 7-membered ring here this is the diazepam or diazo ring here, 2 nitrogens. They're at the 1 and 5 positions, 1,5, hence the name Onfi, 1,5. That's where it comes from. That's how we remember it. And it binds GABA receptors. So you know how Dr. Hamuka was talking about inhibition and excitation. This increases inhibition. This puts on the brakes. Okay, that's how that's how this drug works. People often ask me, you know, how do these drugs work? It's pretty technical, but I think if we keep it simple and talk about excitation and inhibition, that's where we can probably get you guys can understand that. If you're interested in more details, we can talk later. This was approved 5 years ago, and we've used it a lot. This carbazepine is a dibenzazepine, not a benzodiazepine, but a dibenzazepine ring structure related to carbamazepine and oxcarbazepine. What's the difference? Well, when you give oxcarbazepine, when you take oxcarbazepine, it used to be called trileptal, it breaks down fairly quickly into something called the monohydroxy derivative. And the MHD is S and R, carbazepine. They're mirror images of each other. S means left and R means right. Sinister and rector. I forgot my Latin. But anyway, sinister is left. Anyway, so they are mirror images of each other. But this is the S form, not the R form. And the reason is it seems to bind sodium channels better. And this one decreases excitation, so it slows down excitation. So you see the options are increased inhibition or decreased excitation. In both instances, we're trying to slow down how the brain cells fire rapidly, and that's how it works. It has a long half-life, so you can give it sometimes if it works very, very well, 1 pill once a day at night, and that's it. That's actually very, very nice. I would like that if it was me. And this was approved now just 3 years ago. It took a little bit longer to get it on the market. There's always a lag time before it's marketed. So it's really only been on the market since early 2014. Shifting gears completely, lacosamide. This is an interesting molecule. This is unlike anything. This is a protein building block. It's an amino acid. It's unlike anything that's out there. And there's the trade name. And it's used now alone by itself for what's called monotherapy. Or you can use it in adjunctive therapy, which means add-on. And it's for, whoops, oh, I went right to the end. That's not at all good. Oh, my finger, out of control fingers here. It's There we go. So it's used in adults, 17 and above, and it works on sodium channels too. And it's been now approved. It actually was marketed in June, I think June of 2009. So 7 years, lot of experience with this drug, and a very effective compound. This comes as a liquid suspension. So if you have a child or an older adult who has a G-tube in and they can't swallow well, or a child, that has trouble swallowing. When my daughters were little, they liked the lemon flavored trileftal. That was their favorite, actually, which wasn't indicated, by the way. Initially, we didn't know what kind of epilepsy they had. They were on the wrong drug originally, but it tasted good. That was the important thing. And they took it. So it's available as liquid. It's intravenous as well, which is really nice. A really interesting drug is perampanel. And we again talk about excitation in the brain. And there's lots of ways, there's lots of chemicals in the brain that excite us, that push the accelerator pedal, if you will. And so again, sometimes we want to slow down excitation, and that's what this drug does. This works on glutamate receptors. Glutamate's the main excitatory chemical in the brain that drives our brain to go forward and unfortunately forces seizures. So if we could slow down glutamate, that might be a good thing. And it turns out there's 3 kinds of glutamate receptors, and some of the old ones like NMDA, we tried that for years and years. Drugs like ketamine, well, they have their problems. I won't get into that. But there is a different type of glutamate receptor called AMPA receptors. And if we can slow these guys down, that works really well. And that's how this drug works. This is a drug developed in Japan. This is meant to be a sodium channel that's associated with a AMPA receptor. This is AMPA here, and glutamate comes and binds in here, opens the pore, and sodium rushes in. When sodium rushes into our cells, they fire. That's how they fire. Perampanel comes along, and it doesn't bind at the glutamate site. It binds non-competitively down at the bottom here at the linker regions. This is work by Mike Rogoski, who was at NIH at that time and is now at UC Davis in Sacramento. And this is a really effective drug. So it's approved for partial or focal onset seizures. Now we call them focal. It's also approved for generalized tonic-clonic seizures as an add-on drug for older children, older teenagers, and adults. And I'm working on it for a condition called Lennox-Gastaut syndrome. So we're going to be enrolling kids with that and adults with that. This is another drug that's approved for only Lennox-Gastaut syndrome. This is a sodium channel blocker. Unlike any others, it's different. This one has fluoride molecules on it, fluorine, atoms on it. And so different structures, different mechanisms. This one's been around now for a number of years. This is also from Eisai, which is a Japanese company, as is the perampanel. And then I think lastly here, vigabatrin. This one's been around for many years. I was an investigator on this in the 1990s. This one took a long time to get to market because unfortunately it can cause visual field constriction. Interestingly, there's a paper in this month's international journal called Epilepsy, a very important paper that shows that, interestingly, they did a study ahead of time before putting people on the medication, and many people had eye problems to begin with. There was a study done at one of my old institutions where I used to work as a lab tech in Philadelphia called Wills Eye Hospital, a very famous eye hospital in the United States. Bob Surgat, who I knew at that time, still around. Those old timers are still around, I guess. And he published this paper, and I think it's real interesting. So some of the stuff we've seen with vigabatrin may be pre-existing, but you do need to be careful with that medicine. Hence, it's not a first or second choice drug. It's kind of down the list. Okay, shifting gears. What's new? We have some products in development. We have ganaxolone, which is a progesterone-derived drug, but it doesn't have female hormone effects on our body. It actually binds GABA receptors, increases inhibition in the brain, but it failed. We just closed the study. We haven't seen the final results yet, but it wasn't a study that was clearly effective, so more to come on that, I hope, because I think it's a neat mechanism, how it works in the brain, but we are kind of still working on that. Charismate was a drug that was worked on, mostly a sodium channel blocker. Unfortunately, not very effective in focal seizures. The studies were unfortunately designed and conducted rather poorly, the way they wrote the inclusion criteria. They weren't selective enough in being careful about making sure they had people in there only with focal seizures. There were some generalized ones mixed in. And a lot of these studies, by the way, are done around the world. And sometimes if they're done in North America, they're done in Western Europe, they're usually, the selection criteria, the protocols are done well. Other areas of the world, we have had some problems. And so I'm a member of the Epilepsy Studies Consortium, which is Jackie French's program that's out of NYU in New York. And we sit and we look at patients that are going to be enrolled and make sure they really are what the investigators claim they are. So we're trying to get the correct patients in and look at them. We think that's what actually killed Charismate. I don't mean killed, that's a bad word. Stopped development of that drug. But it is going to be looked at for some other things. Dr. Kawaguchi, who you'll hear this afternoon talk on women's issues, who's a graduate of the UW Neurology and Clinical Neurophysiology programs, she will be working on cenobamate with me, which is called YKP 3089. This is a different molecule altogether. It looks very effective, very, very effective. The FDA has already said, we'll approve this drug, but we need more patients enrolled to know if it's about its safety. So we're looking at that. And we have some other studies as well of drugs that are on the market. And then finally, in terms of new drugs that are coming, we have intranasal diazepam spray. Recently, that study stopped. The absorption from the nose into the bloodstream wasn't the same in people with epilepsy as in people without epilepsy. That's a real head scratcher why that would be. There must be some issue there. I can't imagine that there would be a difference. So what's the deal with that? I don't really know. We did find that it burned a bit and people didn't like that. In terms of intramuscular diazepam, the auto-injectors, you just like an EpiPen, you just inject yourself with diazepam. That's coming, so stay tuned on that. And then intranasal midazolam is being investigated as well. Midazolam is a drug that's a very short-acting benzodiazepine, a tranquilizer. This is diazepam here. Both nasal and IM forms. Intramuscular means into your muscle. So we'll see about that. Now, surgery, we've heard us talk about that. I've been involved in doing epilepsy surgery here in Washington now. This is my 30th year. And we like to do it because it's a very effective procedure for many people, but we really like to select them very, very carefully. And there's vagus nerve stimulation. There's a vendor outside who can talk to you about that. That's been around actually since 1997, so it's pretty well known. I won't talk about that. But two things that aren't as well known. Last year when we did this symposium, we did it at Kane Hall, up on the upper campus at University of Washington. We had good attendance, by the way. And Dr. Marty Morell came from Stanford, and she's also a shareholder in the company that makes this device, talked and did a wonderful talk. And I briefly talked about laser hippocampus removal. This is how we remove a hippocampus. That's the inner part of the temporal lobe. For people who have temporal lobe epilepsy who aren't a good candidate to have the typical part of the temporal lobe removed, we'll just remove the hippocampus here. And Dr. Jeff Ogeman, who's a professor in neurosurgery and works here at Children's Hospital and at Harborview. We're part of the UW system at Valley, so we refer all our patients for this procedure to Jeff. And he does these procedures. It's done in an MRI scanner. That's pretty cool. You can do this in the MRI scanner. You can do it same-day surgery. There's no cut on your head, just a little hole. That's it. And I've had worse than that in my body. That's a pretty minimal thing. Of course, the probe goes in your brain. I understand that's pretty frightening, right? But there's a little hole here. These people go home the same day with a Band-Aid on their scalp. I'm not kidding. It's that still freaks me out. I mean, I think of neurosurgery. When Rusty and I started in this business, you were in the hospital for a couple of weeks if you had neurosurgery. Go home the same day with a Band-Aid on your head? Wow, that's pretty amazing. It seems to have a minimal effect on people's memory and speech. And so that's really good. But in terms of its effectiveness, we'll see. We need some time to collect that. NeuroPace is here. I had the good fortune to put the first human implant in a paper boy from Bremerton, actually. He got the first one in the world, and this is it. That's the actual photo. This is a device that records seizures from the brain and then shocks the brain to stop them. We don't have much time left, and I'm being called to task on that. By my watch, we've got 8 minutes, because it's quarter to, yes, quarter to, I think I've got. So I'm going to try to wrap it up in the next 8 minutes. We'll talk about everybody's favorite subject, medical marijuana. And I know that there are some here who, this is not a political rally, by the way. You're not allowed to throw things or stand up, or you can argue with me, but do it politely, okay? And wait till the end. So many patient stories. Now, this is an interesting thing. I have given this talk now. This is at least the third time for the Epilepsy Foundation Northwest. And I'm going to tell you, all you devotees of marijuana, that people have come up to me after the end of these talks and said, you know, Dr. Vossler, I tried that stuff, and it made my seizures worse. So for every one of you that says it makes your seizures better, congratulations, that's great, but it doesn't work for everybody. Do those meds I talked about work for everybody? No. Have you guys tried multiple meds, and did they all work for you perfectly? No. So don't think this is like a panacea here. It's not. But it's worth looking at. And the thing is, it contains somewhere between 60 and 500 active compounds. Marijuana is not one thing. There are many, many things in there. The biggest ingredients, of course, we know, are THC, or tetrahydrocannabinol, which was discovered in 1963, and that's the psychoactive part. And then there's another one, cannabidiol, or CBD, which doesn't have psychoactive effects. It was also discovered a long time ago. And of course, research has been kind of stalled on these for a long time, because this is a DEA Schedule 1 drug. And so it's been hard to do research. But recently, the FDA has said you can do this research, and we'll let you do it. Now, the brain has receptors. I told you about glutamate receptors, like AMPA, and there's NMDA, and gobs of all these receptors. That's where a neurotransmitter is released by one brain cell. It moves across over to the next brain cell, and it binds a receptor. There are endocannabinoid receptors in the brain. Endo means within. So there's cannabinoid receptors in our brains. What are they doing there? Well, we don't really know what they're doing there. They're not there so that marijuana can bind them. Okay, it's the other way around. They're in your brain, and you take the marijuana, and it binds them. That's why marijuana has an effect on you. Okay, there are no rhubarb receptors in our brain. If you eat rhubarb, it doesn't make you high. That's because there's no receptors in the brain. So these compounds are binding receptors that are naturally there. Okay, but that deserves a lot of research. And finally, we're getting that. So there are side effects of cannabinoids, and these are them. And anybody in this room who's using marijuana and blindly ignoring the fact that there are negative side effects of these drugs, really, you need to wake up, because these drugs have negative side effects, just like our seizure medicines do, right? I'm not saying the seizure medicines are perfect, but neither are these drugs. So 3 questions for us if we're going to get this stuff approved and prescribe it to our patients. 1, does it work? Okay, so we need to do randomized controlled trials where you have a placebo group. Okay, somebody takes a placebo. That's a fancy term for a sugar pill. The other ones get medical marijuana, whatever, CBD it is today. Okay, and some of you patients, I know at least one person in the room who's been in one of our drug studies, and they know they got randomized. Why? Because that's the only way we can figure this out. Because it turns out the people who get placebo actually get some benefit too. Why? Well, because they're in a research study, and they're probably taking their meds a little bit more accurately, and they're being careful, and so they do a little bit better. Okay, so we need a control group. That's the only way, because if you look at people who are just taking the med and you don't have any control, what are you going to say? Tolerability, okay, drowsiness, fatigue, munchies, I don't know, whatever, impaired learning memory. We don't like kids getting this stuff. And the problem is kids are getting it. And kids are showing up at this children's hospital and others around the world. Now, babies even being, I'm not saying people with epilepsy are doing this, but in general, kids are showing up overdosing and, being intoxicated, especially with THC. And what is that all about? As a responsible parent, who's giving these children, I'm not talking about kids with epilepsy, I'm excluding those, just general kids. That's wrong. Safety. What are the long-term or serious side effects? Well, that remains to be seen, and I think I would leave that to Dr. Novotny and his team at Children's to talk to you about what does this stuff do to the developing brain permanently. I'm not even going to go there. But I will tell you about the effectiveness. So in 2014, the American Academy of Neurology put together a task force. They published it. Koppel et al. Published it. Here's the reference. They looked at 17,029 different reports for various kinds of problems, not just epilepsy, but other neurological problems. And guess what they found? Nothing. Nothing in epilepsy. Nothing reliable. The Cochrane Library, a very reputable institution out of England, Barbara Vickery, who was a resident here, by the way, Rusty, many years ago. She was a neurology resident and went on to do great things, as many of our UW residents have done. She was involved in this study with David Gloss, who's out of, I think, West Virginia, and here's what they wrote. Couldn't show efficacy or effectiveness. So I'm on the treatments committee. I will be chairing the treatments committee and starting in a month at the American Epilepsy Society, and we put together a position statement and said, well, you know what? We can't recommend it, but we are calling for more research. So guess what? Now we have some research. The research is, there was a class 3 study published in March this year by Oren Davinsky at NYU, also where Dr. Kawaguchi trained. Excellent institution, and it was published in Lancet Neurology, and it was a large number of patients, mixed bag. So what did they get? Well, again, this is uncontrolled. There's no placebo group here, so take it with a grain of salt, but here's what they got. 79% had side effects, and that could have been from what they were on to begin with, okay? So, or maybe they went on CBD. This is with CBD, not THC. Maybe they were on CBD and it kind of made things a little bit worse. 30% had serious side effects. One died. Well, I'm not blaming the marijuana on that, okay? And we heard about that, can rarely die from epilepsy, and that's not uncommon. These tend to be people who are very, very sick with bad epilepsy. So a death, okay, that's probably there. But here's the good news. This looked sort of promising. More than a third of patients, the other way around. Patients had a decrease in the number of seizures by more than a third. So here's where we are with this. And there's a company out of England called GW Pharmaceuticals. They have laboratory botanically grown marijuana plants that produce a large percentage of CBD. No marijuana plant produces no CBD, or no marijuana plant produces 100% CBD. There is always a mix, and they have to purify it. They extract it. It's in a crystalline form, so it forms crystals, and then it's very fat soluble, so they have to dissolve it in oil. And they found that 44% of kids with infants and young kids with a very bad seizure disorder called Dravet syndrome, at a dose of 20 milligrams per kilogram of body weight per day, had a decrease in the number of seizures. But interestingly, they did have a placebo group, and the placebo group was 22%. This is statistically significant. This difference is significant. This is good news for kids with Dravet syndrome. Similarly, with Lennox-Gastaut syndrome, don't worry about what that is if you don't know. I can tell you at the break. But again, compared to placebo, at 10 or 20 milligrams per day, it was statistically significant. Results are still coming in. There were 2 studies here, 2 studies here. There's one in tuberous sclerosis, a different kind of a genetic syndrome which causes epilepsy. These studies, these 4 studies of these 2 syndromes will be submitted to the FDA early in the first quarter of next year, and it's going to take 9 months for the FDA to act on it. On average, it's 8 months, and then 3 months. The DEA now must certify it within 3 months. They can't diddle around like they did. It took a year with one of our antiepileptic drugs, which was absurd to put a schedule number on it. Come on, get going. They're being paid tax dollars. Let's get it on. So here we go. What do we conclude? Laboratory-grown, research-grade CBD appears to help some people somewhat, but I would say it's not 100%. There are side effects, but this is the thing, guys. When you go to a local marijuana shop and you buy something from someone that's got tattoos all over themselves and earrings and nose rings, and they don't know where they got it from. I want to know this: how much THC is in there, how much CBD, and it's been shown that what's on their labels is not trustworthy. How much in the way of pesticides, herbicides, animal feces, fungi, and bacteria are there, and how much are you going to take into your body? Unknown. I can tell you this, in my experience now that CBD or whatever medical marijuana use is rampant in the state, my patients with epilepsy really, honestly, and those of you who use it, I think you're using it more, and they tell me they're using it more to treat their existing depression and anxiety than their seizures. And so I would say stay tuned on this, but the news is looking pretty favorable. So there's new definitions and new terminologies. You need to know them. You just can't run away from it. You need to know them. You need to be excited like I am. You can tell I'm pretty enthusiastic about this, about our new medications and ones that are being researched. We have new surgeries, a new device, and cannabidiol remains to be seen, but does show promise. So with that, thank you very much. So let's break. Let's take a break, and then I'll stick around for questions. Thank you very much.